Okay, so welcome to week 8. I think what I've seen is there's going to be a bit of pop health at the start, and then some micro, I think a bit of PHARM, and then some CLIN skills, so a bit of everything. So I'll start with pop health. We've got screening and diagnosis, which is quite an important topic. It kind of carries on into year 2 as well. So I'll talk about firstly the difference between a diagnostic test and a screening test. So you're probably more familiar with diagnostic tests at the moment. So that's pretty much someone comes into the clinic and they have a certain symptom, and then you can use a test to see whether or not they have a specific condition. But then a screening test, we kind of use them on people who don't have any symptoms at all, and just anyone in a certain population. So the reason why we would do that is just to see and be able to detect early on in a disease before a symptom might have even appeared, to see whether or not someone has a condition. So that's often done with things like cancers, like breast cancer, colon cancer, because with those diseases, if you detect them a bit earlier, you can usually treat them better. So more on the screening tests. So there's 4 different types. There's mass, which is just screening everyone in a certain population. Then you have multiphasic. So this is when you kind of have sequential tests one after the other that you're giving out on a population. Then you have targeted. So you're within a certain population, you're targeting a group in there that you think might be of more risk of a particular condition. So that's often done with things like age. So people of a certain age are targeted for, say, breast cancer. And then opportunistic screening is when you kind of go into the GP and for like a sore wrist or something, and then while you're there, they'll probably screen you for other things, like look at your cholesterol or see certain other risk factors that you might have, or any diseases. So some requirements of screening tests, there's a lot there. So be familiar with the different requirements, but I think the main ones would be, firstly, the fact that the disease has to be well defined, which is kind of a given. If you're screening for anything or testing for anything, you need to know what a positive means. But then also I've bolded like the main ones. So the third one there kind of talks about that there needs to be a time, quite a long period of time between when you get the disease and when you start presenting clinically, because otherwise there's not really much point in screening, because you would just then, if there's not much of a difference, you could just come into the clinic once you start presenting with symptoms. Also, the fact that there should be some kind of treatment and the facilities to treat if someone receives a positive. So if we screen for, say, breast cancer, we need to, and we detect that it's there, even though symptoms haven't presented yet, there needs to be the right facilities to treat it. Otherwise, there's no real point of screening in the first place. Okay, so sensitivity and specificity, these are 2 main concepts that you'll have to be familiar with even into second year. And they're very examinable as well. So just be familiar with them and also how to calculate them. So sensitivity, this is the proportion of people who have the disease who will test positive. So I guess for people who are a bit like easier with numbers, the formula might help a little bit more to understand what that means. So we've got A, which is everyone who has the disease and is positive over every single person who has the disease. So that includes people who also tested negative. And then with specificity, that is the proportion of people who don't have the disease who tested negative. So kind of the same idea, but you're using people who are without the disease who tested negative over everyone who doesn't have the disease. And a key thing about this, compared to the next few values that we'll talk about on the next slide, is that sensitivity and specificity are properties of the test. So when you talk about it, this specific test has a high sensitivity or high specificity. Whereas when we look at positive predictive value and negative predictive value, these are not properties of the test, and they will change according to the prevalence of a certain disease. So if the prevalence of a disease is quite low, then these values, so PPV and NPV, will change. So positive predictive value, this is the proportion of people who have a positive test who have the disease. So we're kind of looking, our number down the bottom here is everyone who's tested positive, whereas on the last side, our number down the bottom is everyone who has the disease. And then with the negative predictive value, it's the same kind of concept, but instead with the negative test. So proportion of people who have a negative test who don't have the disease. Just know how to calculate these values because you probably get asked. And then when it comes to screening and diagnosis, we have two key biases. They can be a bit hard to get your head around and they sound very similar, so you might get them confused. So there's lead time bias, which is where because you're screening for a disease, you're going to detect it earlier than someone who would have come in for the same disease, but when symptoms started. So I'll use breast cancer as an example. If you did screening and you get a positive when you're 30, but you wouldn't have presented till you're 40, with the way that it's recorded, there's this bias is kind of describing that, say if that same person died at 50, the screening is gonna make it seem like because she got screened, she lived for 10 years longer than she would have if she didn't get screened. But that's not really true because she still died at the same time. So that's kind of the bias that's there, where it looks like someone survived for longer with a disease because the screening kind of just detected it earlier, even though the treatment might have not been any better or screening wouldn't have affected the course of their disease and they ended up dying at the same time anyways. Similarly, sorry, not similarly, on the other hand, with length time bias, this is more when you're more likely to pick up a disease if it's less aggressive. So if a cancer is very aggressive and it's very and it progresses very fast, you're probably going to present clinically quite quickly before you even get time to screen. So screening is not going to really pick up many of those. Whereas the less severe, the less the diseases that have less of an impact, I guess, they are picked up more in screening because you're not presenting to the clinic for them. So this can lead to something called overdiagnosis. And overdiagnosis is kind of when you go get screened and then they find out that you have a disease, but you would never have presented with symptoms in the first place or had any issues with it. But now that you've kind of detected this illness, you're gonna get treatments for it, and those could have harms in themselves. So most treatments will have their own risks. So that's kind of an issue that will pop up with screening, where if you screen, you might end up exposing a person to tests and all these procedures that were probably unnecessary and also harmful. And that's why in back here, so in some properties of the screening test, the disease has to be serious. So that way you're not kind of detecting a disease that could have been fine if you didn't even know it was there. And I think that's pretty much all for pop health.
So I'll be presenting on micro and also on micro epidemiology and also micro infections of the CVS. So let me just get my share screen up. Okay, so this is a bit of an interesting lecture. It kind of jumps around a bit, so I'll just take you through it. But pretty much, what is epidemiology? So epidemiology is, for a quoted definition, it's the study of the causes, frequency, distribution, and determinants of health and disease, morbidity, disability, and mortality in human and animal, but that's not so relevant to us, populations. So epidemiology is pretty important, especially when considering infectious diseases, because we do need to know a lot about like how a disease was caused or how somebody came into contact with another person, because that plays a major role in how we can stop the spread of infectious diseases and then stop the morbidity and mortality as well. And often in outbreak settings, there's a need for urgency. So we saw with COVID, like there was a need for urgency to try and stop like the transmission of COVID. And that was really important. So epidemiologists played a really important role in trying to stop these infectious diseases. So just a quick review of disease transmission. We've got our susceptible host, our infectious agent, our reservoir, our portal of exit, mode of transmission, and then portal of entry. So you'll go over this like so many times. We went over it a bit a few weeks ago when we talked about bacterial pathogenesis, and you'll go over it a lot in year 2 as well. So just knowing your 6 steps for the chain of infection and how they kind of like all link together to create then that kind of cyclical state of the disease transmission. So a few key definitions to know to start off with. So we've got incubation period. So the incubation period is the period between your exposure to the infectious agent and the onset of your symptoms. So this could be like, for example, with COVID, the incubation period used to be thought to be 14 days because that was like when you had contact with a known case. And then when you developed symptoms, they usually said to allow 14 days for that to happen. You can be infectious during your incubation period as well. And the incubation period is variable by the disease. So like it varies by disease. Example, like chickenpox will have a different incubation period to measles, but it's also variable within the disease. And this kind of changes based on the person, like each person who catches that disease. So like immunocompromised people may have a very different incubation period to someone who like has a fully functioning immune system as well. Like they might be able to fight it off for longer. So somebody with a normally functioning immune system may have a longer incubation period than someone who is, say, immunocompromised. So next definition is clinical disease. So clinical disease is when you have your symptoms of infection. So it's the time from the onset of illness defines the duration of incubation. And then clinical disease, the period is also known as the notification date in surveillance data. So if you're like performing data, for example, like COVID, when you have to report your rat tests, like that is your clinical disease period. Your latent period is the time from infection until you're infectious. So this generally happens during the incubation period. And your infectious period is the time during infection that the person can transmit the disease. So just here is a little summary of what I did in the previous slide. So you can see here, you've got your latent period, your infectious period, your incubation period, and your clinical disease. And you can see that the infectious period kind of lasts through the incubation period and the clinical disease as well. And these obviously do vary from case to case and like disease to disease. So a quick overview of morbidity versus mortality. Morbidity is the cases of disease in a population, and mortality is the deaths from disease. So this is often spoken in terms of like rate. So it's like how many deaths you have from the disease divided by the number of cases of disease. So R0 is the number of cases that one case generates on average over the course of its infectious period. So for example, if somebody had a disease and then they infected 3 other people, the R0 would be greater than 1. But if somebody had a disease and like on average only 0.8 people get infected from that one disease, then your R0 would be less than 1. So the aim in epidemiology, I guess, and in disease control is to try and get your R0 less than 1, because if it's greater than 1, it's a lot harder to control. Your disease prevalence will increase, but if it's less than 1, your disease will decline. Like it will become less and less popular in society. So some known R0s, you've got measles, which has a very high R0 of 12 to 18. So for every 1 person, they can infect, like on average, 12 to 18 other people, which is why measles is such a contagious disease. Like it's such a problem when there is an outbreak. Otherwise, you've got things like polio, which is still pretty infectious. So 5 to 7 people, that's quite a high R0. All of these ones that I've included have got quite R0s, quite high R0s. And COVID at the start of the pandemic had an R0, I think, of about 3, but now it's dropped right down. So that's like an example of how public strategy can also like help to decrease the R0. So factors affecting it are in duration of infectious period, in infectivity of the agent, and also the number of susceptible people in the population. So like that could be unvaccinated individuals, that could be like immunocompromised individuals, people with other comorbidities, like all these sorts of things can also affect the R0. So if you have a look here, this is just a little diagram. This one comes straight from the lecture slides. So I'll just leave this one here, but it pretty much nicely summarizes different factors that can influence the R0. Herd immunity. So immunity is pretty much the capacity of someone to remain free of the infection or the disease, or like not present any clinical signs or symptoms when they're exposed to an infectious agent. So herd immunity is, as it seems, like the immunity of a group or community. So different diseases have different thresholds for herd immunity. So for example, measles has a 90 to 94% threshold. But like there are other conditions and diseases where you only need like a 60% threshold for herd immunity, because it's just not that, it doesn't have a very high R0. So generally diseases with a really high R0 will have a higher threshold for herd immunity, just because it's so infectious. But like diseases that don't have a high R0, you might only need like 60% of people to be immune in order for herd immunity to be achieved. So some final terminology. You've got your index case, which is the first case in the population. This one might not always be identified, but if it is identified, it can obviously indicate the disease source. Primary case. So primary case is often used interchangeably with the index case, but the primary case is actually the first case which is identified and notified. So it doesn't always have to be the index case, but it's just the first case which is actually like properly published, properly notified, all that sort of stuff. And then secondary cases are just cases resulting from further transmission. So your 3 steps in an outbreak investigation is to identify your primary cases, identify the sources of the epidemic, and you also need to know like the incubation of the disease, the latent period, and the infectious period as well. So an example, we've got dengue fever, which is a virus transmitted by mosquitoes. So it comes with headache, fever, rash. It's usually self-limiting, but it can be quite severe. So an example of this is taken straight from the lectures again, was an extra case noted in the end of December, just during like regular weekly surveillance. So there were more the next 2 weeks showing the emergence of an epidemic. So the plan of action for this is education, public education, spraying mosquito breeding sites, and also like educating like public health officials in the recognition of warning signs. So that allows like triage in emergency departments to try and reduce the R0 period. So a few little more definitions. I know I said they were the last step, but there are more. Pandemic is an epidemic which occurs worldwide or over a very wide area, which crosses international boundaries and usually affects a lot of people. And then other levels of disease occurrence. So we've got sporadic, which is kind of like occasional cases occurring at a regular interval, so it's unable to be defined. Endemic is something that has a persistent occurrence with a low or moderate level. Hyperendemic, you've got a persistently high level of occurrence, but it's not like anything unusual or unexpected. And then an epidemic or an outbreak is something which is clearly in excess of expected level for the given time period. So that's when you kind of start to get a bit more worried, I suppose, when you see an epidemic or outbreak start to form, because then like you're obviously not expecting those levels, so it's abnormal. So for an epidemic, you need 5 real things. So you need a susceptible population that doesn't have immunity, so a virulent agent. This often means like you need a kind of new virus as well. You need opportunities for exposure, whether that be like coughing, like touching people, all those sorts of things. You need slow recognition of a problem, so like a slow picking up of this until it's like been successfully transmitted to enough people for it to be an epidemic. And you also need quite a fast incubation period, because if it's got a really slow incubation period, chances are it just won't be able to spread quite as quickly. But if it's got a quick incubation period, then that's when it becomes really dangerous. So 12 key factors in emergent infectious diseases. So we've got microbial change, which can be like new agents coming or new increased transmissibility. You've got human susceptibility to infection, so how susceptible someone is. Population growth is also really contributing, along with urbanization and crowding. Breakdown of public health infrastructure. We've got war, social dislocation, which can also lead to bioterrorism, refugees, like lots of, this kind of links back to numbers 3 and 4 as well, with like crowding and density as well. The globalization of travel and trade, which means that it's more easy for like viral agents to move from place to place. You've got live wild animal markets, so bird flu is a key example of that. Livestock production, misuse of antibiotics, which can lead to resistance, changes to the ecosystem, so like deforestation, biodiversity loss, and also climate change. So that's just something I think you'll have to memorize. I mean, when you think about it, it's pretty self-explanatory, but yeah, just something you'll have to memorize over time. All right, so what should we do? Pretty much just enhance surveillance, encourage applied research, so new techniques for surveillance, diagnosis and intervention, and also just make sure that public health infrastructure is strengthened as well. So now on to micro for cardiovascular infections. This is quite a big one. I'll start with infectious endocarditis. So this is the condition that you really need to know the most about. The other ones are like not so much high yield, but this one's pretty big. All right, so what is infectious endocarditis? So it's an infection of the inside surface of the heart. So generally the heart valves, you've got your tricuspid valve, which is the most affected one. So that's 50% of the time. You've got your mitral and aortic valves, which also make 38% of cases. It's actually in the top 4 of the most common life-threatening syndromes, and it's usually caused by gram-positive bacteria, especially Staph aureus, but also strep and enterococcus. It can also be gram-negative bacteria and fungal infections. Okay, so how is this transmitted? Through a breach in the skin, so you have injections, IV cannula, cardiac surgery, and pacemakers, skin and soft tissue infections. So you've got a whole bunch of different ways that the skin can be breached, and this is how the IE can get into you. Oral cavity as well, so you often see this after dental procedures as well from poor treatment, like poor infectious control during dental treatment, and also just poor dental hygiene, like abscesses, which the infection can find its way into. So the pathogen gains the entry to the bloodstream, then it adheres to the valve surface in the heart, and it builds like a big colony of this bacteria. The bacteria persists, the bacteria proliferates, and the bacteria can also break off and disseminate into other parts of the body, which can cause septic shock. So risk factors for IE, we've got valvular heart conditions, prosthetic valves or pacemakers, and if either of these are infected, then you do need a replacement. IV drug use is another risk factor, skin infections, and also central line access. So pretty much any conditions in, or any, conditions in which the skin, like the intact skin can be broken and then bacteria can be allowed in. So signs and symptoms, a good mnemonic is from Jane. So we've got fever, Roth spots. If you have a look at this, this is actually in your eyes, but you've got like little hemorrhages with pale centers here. That's a Roth spot. That one's probably harder to spot because you're not like looking directly at someone. You have to have like an ophthalmoscope to be able to do that one. So that's probably not your first sign or symptom that you'd see. Osler nodes, which you can have a look. They're pretty painful nodules on the tips of fingers and toes. A murmur in the heart because the valve is obviously becoming more and more blocked from this bacterial congestion. Janeway lesions, which are on the palms of the hands, they're non-painful. So Osler is painful, Janeway is non-painful. Anemia, signs and symptoms, hemorrhages in the nail beds. So you'd be looking at the, not very helpful with my nails because they're painted, but you'd be looking at the nail beds and seeing if you can see any signs of hemorrhage there, and also emboli. Okay, so acute IE is very aggressive. It's a matter of days. Generally, it's due to very virulent organisms, for example, like Staph aureus. And subacute is quite a slow course. So it's less virulent organisms like Enterococcus or Strep viridans, and it usually has abnormal presentations as well. So I'm just going to give you 4 scenarios that you should memorize. So dental work, you'd be seeing viridin streptococci, and this is a dental flora, which just like is resident in you. Valve replacement, you'd be looking at Staph aureus. An IV drug user, you'd also be looking at Staph aureus, which is also a resident skin flora, and colonoscopy, you'd be looking at enterococci, which is a resident GIT flora. So if you can just kind of learn these kind of 4 scenarios, they're very important because you might be asked this in an exam. Okay, complications. We've got the signs and symptoms that I mentioned before, so the from Jane. You've also got cardiac signs and symptoms, so like heart failure, valvular rupture, perforation, kidney problems, septic shock. So this is when like the bacterial emboli can become dislodged and they travel around the body, and obviously that would then cause systemic effects, including septic shock. Mycotic aneurysms, which is when you have an infection of the vessel wall. Embolic phenomena, so you've got a stroke in 17% of cases. So that's actually quite a lot of cases. and death. It is fatal if left untreated. You've got about 15 to 20% mortality if it's treated in hospital, and after 1 year, the mortality is about 40%. So it's pretty bad. So for diagnosis, investigations, there's the blood culture. You need to do 3 sets of blood culture generally. And the first and last need to be more than 1 hour apart. So they need to grow whatever the organism is. White cell count as well, C-reactive protein, looking for signs of infection, and microscopy of the swabs that you've taken. You could do an echocardiogram. A transthoracic is non-invasive, but it is limited by the chest wall, or a transesophageal echocardiogram, which is more invasive, but you get better views and you do it under anesthetic. Otherwise, you can do a chest x-ray, an MRI of the brain and spine, and CT of the chest. So diagnostic criteria, to say you've got a definite IE, you need pathological criteria, so culture, histological examination of the affected region, and then clinical criteria. So you need 2 major criteria, so like the blood culture or an ECG, or 1 major and 3 minor criteria, for example, like a blood culture, or like predisposition, all the symptoms and that sort of stuff, or 5 minor criteria. So that could once again be like predisposing risk factors, or like 4 symptoms. So you need, that's to rule in a definite IE. And to do a possible IE, you need 1 major and 1 minor. So 1 major being like a blood culture or an ECG, and 1 minor being like symptoms, or 3 minor criterion. So like symptoms like Janeway lesions, Osler nodes, and predisposition, those sorts of things. Okay, so if your blood culture comes back negative, you can't rule out an IE because the patient might already be on antibiotics. So that's really important to get in the history that the patient isn't on antibiotics. It could be a different type of IE as well, like a subacute or chronic IE, which is actually harder to detect because it's got an abnormal presentation. It might also be due to relatively slow growth organisms. So Staph aureus will obviously be quite a fast growing organism, but there are other organisms which might be quite slow growth. It might also be due to a fungal cause, and fungal won't grow on a bacterial culture. So it's really important that even if you do see a negative blood culture, you can't rule out infective endocarditis. And then treatments wise, for pharmaceutical treatment, we've got benzyl penicillin, 4 hourly, delivered via IV. You've got flucloxacillin, 2 grams hourly on IV. Gentamicin, which is just a daily IV for negative gram cover. And then prosthetic, you've got, the only difference is vancomycin instead of benzyl penicillin. And you'd use vancomycin for possible multiple resistance. You actually do need to do this treatment for quite some time. So if you do have infective endocarditis, you'll probably be in hospital for greater than 4 weeks, just because all of these treatments do go on for longer than 4 weeks time. So even if like your symptoms do resolve, you still have to be on these antibiotics, and it is like hourly and 4 hourly, which is pretty intense. So you'd want to be in hospital for all of it. And to try to prevent this, they often give 2 grams of amoxicillin before cardiac and dental procedures, like as a prophylactic measure. Like if you've got heart failure or abscess formation as well, surgical treatment can be taken to kind of remove that formation. And sometimes, like if you've got a prosthetic valve or a pacemaker in, then it will be replaced at this time as well. Okay, myocarditis. So that's the big bulky one done. The other ones aren't so bad. So myocarditis is inflammation of the heart muscle. So this might affect the muscle function and also the electrical conduction and lead to arrhythmias. So it's often caused by viral infections, but sometimes bacterial infections, and sometimes it's also due to drug sensitivities. Signs and symptoms. So diagnosis is not usually made because it's quite difficult, but it can actually lead to sudden death in young children. So it's actually found incidentally in 1 to 4% of postmortems. So signs and symptoms, you've got chest pain, arrhythmias, shortness of breath at rest, fluid retention, fatigue, fainting, or other viral infection symptoms like a sore throat, a fever. So you can see why it's kind of a difficult one to diagnose exactly, because it's quite similar to a lot of other cardiac conditions. I do know that you guys haven't done any cardiac, any CVS yet. So this whole presentation might be a bit confusing, but you will, like, when you come back to it for revision, it'll make a lot more sense once you've done anatomy and physiology and all that sort of stuff. So just bear with me while I present this and it'll become helpful later. Okay, so for diagnosis of myocarditis, you've got PCR, so growing of the virus. You've got MCS, so microscopy of the samples. You've also got histology and sometimes a biopsy. Complications can be heart failure, heart attack, stroke, arrhythmias, and sudden heart death. So it is quite a bad one again. And it's more difficult to diagnose than IE as well, because there's not that sort of like diagnostic criteria. Pericarditis. So this is inflammation of the 2 layers of the fluid-filled sac-like tissue lining the outside of the heart, which is otherwise known as the pericardium. So the cause is largely idiopathic. When it is known, it's predominantly viral. So viruses like the Coxsackie B. It can also be trauma-caused inflammation, autoimmune diseases, cancer, and radiation therapy. Signs and symptoms, you really just see fever, chest pain, which is worse when you kind of like try and breathe heavily, because obviously your heart is surrounded by this pericardium, and like when you breathe in heavily, it can cause it to press against things, which can like make the chest pain worse. And large pericardial infusions you might see as well. So you'd have less heart sounds, a lower cardiac output, which could lead to shortness of breath, low blood pressure, and lightheadedness. Diagnosis and complications. So diagnosis, you do this thing called a friction rub, where you rub like on the sternum, and if you hear, you listen. You can also do an ECG, a chest x-ray. You'd be looking for the water bottle sign. So I don't know if you see this, but it's quite largely like ballooned out, and this is due to the pericardial effusion. You can do an echocardiogram, which I realized I wrote twice. PCR, MCS again, and histology. So all just depending on the cause. Complications, you've got a pericardial effusion, which is when your pericardium, so that's like the fluid-filled sac surrounding the heart, it thickens, the fluid pools, so your pressure builds up and prevents the heart chambers from fully filling, because like if you think about it, you've got all this pressure coming onto the heart, so then it's unable to fully fill and like pump all the blood back out. And fibrosis as well. So if the inflammation keeps going, your pericardium gets pretty stiff, and this leads to your heart having trouble fully contracting and relaxing as well. So these can have some pretty long-term heart problems. Okay, we're on the home stretch. Acute rheumatic fever. So it's an autoimmune response to strep throat, where antibodies can cause damage to the heart, because the antibodies that react with the strep pyogenes also cross-react to the heart valves, and if this keeps like happening, this can lead to rheumatic heart disease, because the antibodies just keep attacking the heart valves, which is not great. So this I'm just putting in, this is like completely from PS Platypus, because we didn't actually learn this, but just in case like it's useful, you can go back and read this in your own time if you're interested. But it's just like other really low yield conditions, so like thrombophlebitis and mycotic aneurysm. We did cover a mycotic aneurysm actually when I was discussing IE as well, though, because it's due to the bacterial infection. Okay. Finally, we've got pyrexia of unknown origin. So a pyrexia of unknown origin is when 3 things happen. So you've got a fever of higher than 38.3 degrees Celsius on multiple occasions, so more than 3 times. You've got an illness of more than 3 weeks duration, and you've got no diagnosis is able to be made after 1 week of inpatient investigation. So at that point, you can say they've got pyrexia of unknown origin. But this is not an excuse to give up on diagnosing the patient, because PUO is not just a diagnosis. It's just saying like they have unknown like origin for this. So causes, you can have infections, inflammatory causes, neoplastic causes, and also unknown causes. So like it's a pretty, it pretty much is when you actually can't diagnose the patient. Oh, thank goodness. Wait, is that the end of me? No. Sorry, my computer's just glitched. There we are. Diagnosis. So to diagnose, you've got to confirm the presence of the fever. So the 3 times when you've got greater than 38.3. Retake a lot of history. So like kind of just go back over everything. See if there's anything you might have missed. So past medical history, social history, family history, travel, drugs, like all the works. Look for lymph nodes, look for hepatosplenomegaly, look for thrombophlebitis, look for tender temporal areas, look for everything like cardiac murmurs, rashes, anything you can look for, do. So this is like something where you really do have to go back and consider the body as a whole, and how different systems might interplay with each other. Do more culture tests, do more imaging. So the key point is pretty much don't stop with a diagnosis of PUO, but try and find an actual diagnosis. So just because you're like, oh, yeah, they've got pyrexia of unknown condition origin, that doesn't mean that the diagnostic process can just be given up. So that's the key takeaway. And I think that's it with me. Yes.
Okay, brilliant. So I'll be taking us through the pharmacology lecture for this week. And this week's topic is quite an important topic. It is essentially looking at the role of opioids in the management of pain. And this is particularly quite a relevant clinical lecture because opioids are commonly used in things such as post-surgery care, management of chronic conditions, particularly back pain, those kind of things. So looking at our learning objectives today, we're just going to be essentially looking at opioids, the mechanism of action, when we would use it, any side effects, and lastly, what we call the analgesic ladder. So I covered earlier in the term simple analgesics and NSAIDs. Today, we'll be looking at opioids, which are another class of medication used to relieve pain. And the core drugs that we will look at today are the ones that are listed in your lecture, and definitely be using PHARM and the AMH guidelines as well for information on these drugs. So looking at a brief overview of opioids, they're also sometimes known as narcotics, and essentially they act centrally to produce morphine-like effects. So this is things associated with pain relief and euphoria. But before we understand the mechanism of action of opioids, we should take a look first at the transmission of pain. So we're going to be looking at the nociceptive pain pathway, and essentially pain will usually begin at nociceptors, which are branching ends of sensory neurons found within the peripheral nervous system. Here, transduction will occur. So next, we've got our primary sensory neurons will transmit the painful stimulus to secondary neurons, which are located in the dorsal horn of the spinal cord. Okay, so this second step here is transition. And yeah, so essentially these high threshold primary sensory neurons will respond to the pain by transmitting this painful stimulus to the second order neurons in the dorsal horn of the spinal cord. Again, we have another transmission step. So the pain is going to be carried through the spinothalamic tract to the thalamus after it has been transmitted. So pain will be taken through the spinothalamic tract to the thalamus. Next, the signal will travel to the somatosensory cortex. This is where pain is perceived. So we've got a bit of transmission here, then turning into perception. So we've got a few different nociceptive fibers that you guys might have come across already in physiology. But first we've got our A delta fibers, which are for fast, sharp, and localized pain. And these go through the neospinothalamic tract. And then we've got our C fibers, which are responsible for slow, dull, and diffuse pain, which is through the paleospinothalamic tract. These tracts are branches of the lateral spinothalamic tract, which is responsible for pain and temperature. It's important not to get confused with A beta fibers, which are another nociceptive fiber, because they're not related to pain, they're related to touch. So important not to get those confused. In the context of opioids would target C fibers, so they're acting to counteract slow pain. Okay, this is just taken directly from the lecture notes. There's a little bit more information about what we consider fast pain and slow pain, but just the key takeaways are A delta pain fibers are associated with your sharp, fast pain, the short in duration, while C type fibers are associated with the longer duration, the dull burning pains, the ones that are difficult to endure. So opioids will be acting on the C type fibers. Key takeaway there. Okay, so opioids as a medication are opioid receptor agonists, and they prevent the transmission of pain signals, particularly C fibers, by acting at mu receptors. So mu receptors are where most of the analgesic effects will occur, but you've also got two other receptors that have some analgesic effect, but mu receptors are the most common one. In terms of the mechanism of action, essentially we have activation of the potassium current via potassium channels, resulting in hyperpolarization, and then reduction of the calcium current by inhibiting calcium channels as well. So we've got both of them occurring at the same time. So here are some clinically used opioids. We have codeine, morphine, oxycodone, and fentanyl. So they're all going to have the same mechanism of action. They're acting at the mu receptors in the central nervous system, reducing transmission of the pain impulse and modulating the descending inhibitory pathways from the brain to produce an analgesic-like effect. For codeine, it's typically used in severe pain and cough suppression. And morphine is essentially the activated form of codeine and is also used in severe pain. Oxycodone is typically used in chronic pain as well. All of these have quite potent side effects. So we've got a number of gastrointestinal symptoms, so nausea, vomiting, dyspepsia, which is discomfort in the upper abdomen. We've got side effects associated with cognition. So we've got drowsiness, dizziness, headache. We've got orthostatic hypotension, itch, dry mouth, meiosis, urinary retention, and constipation. Fentanyl is, out of the opioids that you will learn this year, is the most potent opioid. It is used in moderate severe pain. And you've also got rash, erythema, and bradycardia associated with that opioid there. We've also got tramadol and loperamide. So tramadol, again, is a very similar mechanism of action, and your analgesic efficacy will result from the release of noradrenaline and 5-HT in the dorsal horn. It is often used in the case of severe pain. And then we've got loperamide, which is a potent antidiarrheal, and basically it activates opioid receptors in the gut wall, decreasing bowel motility and increasing fluid absorption. So its indications are diarrhea. So this is a really key one that you could be examined on. And some of its side effects are very much gastrointestinal related. So we've got abdominal pain, bloating, nausea, vomiting, and constipation. It is important to note with loperamide that there's no actual analgesic activity because it's limited to the gastrointestinal tract rather than acting centrally. Okay, taking a closer look at some of the adverse effects. So a slowing of your gastrointestinal tract is going to cause constipation. If your CTZ is triggered in the CNS, so that's the zone in the CNS that's responsible for nausea and vomiting, you can get those symptoms there. The release of histamine from mast cells is going to be responsible for your itchiness, your rash, your bronchoconstriction, and your hypotension. But if you take too much of an opioid, a key adverse effect is respiratory depression. And to treat this, you would use naloxone, which is an opioid receptor antagonist. So it's going to, not inhibit those receptors, it's going to work opposite to the agonist. This here is a look at the analgesic ladder. So essentially, this is kind of what you would prescribe depending on the intensity of pain. So if you have very, very mild pain, you're not going to prescribe an opioid, you're going to prescribe non-opioids, which are going to include things like simple analgesics and NSAIDs. So your paracetamol, your aspirin, your ibuprofen, and just other NSAIDs and simple analgesics. Next, if the pain increases in intensity, so we're going from mild to moderate, you would prescribe a weak opioid as well as a non-opioid and any other appropriate therapies. So this could include codeine, tramadol, which are fairly weak. And then in the case of severe pain, that's when you would use your much stronger opioids, such as oxycodone and morphine. So that concludes opioids. As always, any questions, just send me a message.
So our last bit for today is about lower limb neuro, so part of CLIN skills. The best thing about this particular topic is it is just kind of repetition and putting together of the last 2 weeks that we've done. So it's very similar to upper limb neuro, just translated to the lower limbs. And it also involves gait that was done last week. So yeah, this one should be quite good. So just to start off, we have here a diagram for the lower limb dermatomes. We're not going to really go through it now because it's quite self-explanatory. So just feel free to use this to have a look. Yep, and also a list of myotomes here. So when we're talking about the hip, flexion is L2, L3, extension is L5, S1, S2, abduction is L4, L5, S1, and adduction is L2, L3, L4. For the knee, you have flexion with L5, S1, and extension is through L3, L4. For the ankle, for plantar flexion, you have S1, S2 involved, dorsiflexion, L4, L5, and then both for inversion and eversion, you have L5, S1 involved. And then we also talk about the big toe separately because you've also got extension control by L5 for that one. Yep, so whenever we're doing our examination, as always, we are going to start off with inspection. So that includes general appearance, as always. Also with this one, we're looking at posture of the patient, any sort of visible abnormalities on the skin, so scars, rashes, etc. Any abnormal movements such as tremors, any fasciculations, muscle wasting, particularly for lower limb, we're looking at the quads and calves. And we're also going to look at gait. So if you'd like to go through gait in like lots and lots of detail, that was last week's session. So feel free to go back and check those slides or that video. But just like a little bit of a summary of some of the things we're looking at. So we're looking for Romberg's test, where the patient is going to stand like still with their hands by their side and their eyes are closed, and just notice if they're sort of tipping over or falling over. You're also going to be testing the S1 route, so get the patient to walk on their tiptoes. The L4 and 5 route would be walking on their heels. And then for cerebellar lesions, you're looking at walking like heel to toe in front of each other like that. The last thing there is the Trendelenburg gait. So there's a diagram of it just here. You can see that it kind of indicates weakness in the hip abductor muscles, which those muscles are supplied by the superior gluteal nerves. So those are like the glute muscles. And if you have a positive sign for this, that indicates the patient has weakness in the hip abductor muscles. And that's where, say, for example, if a patient has weakness in one particular side of their hip, when the patient stands on that side, so on that leg, the pelvis on the other side is going to drop. So you can see in this diagram here, the patient is standing on their left leg and then their right side drops. So this is, it's actually more to do with like the stance part of how they walk. So I'm sure you guys have gone through like the gait cycle, or you're about to go through that. So you've got the stance phase, which is all of the time throughout that cycle when the patient is just standing still almost. And at those times, that's about like 60% of the gait cycle. That is where you would see this sort of difficulty or this Trendelenburg gait specifically, but because it makes up like 60% of the cycle, you'll see it throughout the gait. And just to kind of make up for the fact that their hip is leaning, or their pelvis is leaning like that, the patient themselves will try to lean to kind of compensate for that. So that's another way for you to be able to see it. You'll also see the patient kind of slant over a little bit. And if the patient has difficulty in both sides, so there's weakness in both sides of the hips, so both hip abductor muscles are affected, in that case, then they're going to have more of like a waddle rather than like leaning on one leg. So these are all different ways that this can present and something to look out for. Yeah, so as we did with upper limb, we're going to just go through the motor system first. We have tone for the lower limb. As always, tone is just the freedom of movement of a joint when moved passively. And if you have increased tone, that's hypertonia. If you have reduced, that's hypotonia. Another thing we're looking at is clonus. So if you have any sort of problems with clonus, so you see clonus here, then that means there's a problem, like there's an upper motor neuron lesion. So a clonus is defined as sustained, shaky, sort of involuntary muscle contractions while it's stretched. So while a particular area is stretched. So if we're seeing clonus in the ankle, to test for that, you can bend the knee, externally rotate the thigh, and then sharply dorsiflex the foot, and you'll see that movement. And then in the patella area, so your knee, extend the knee and sharply move the patella down and observe what happens there. And the other aspect we're looking at here is power. So we've talked about power quite a lot. As always, you've got the scale that you grade muscle power through, so from 0 to 5. And yeah, power is the strength through resistance. So there's always that resistance happening. And just a couple of tips. Whenever you're testing power in a particular part of the body, so including in the lower limb now, it's always good to isolate the muscle like above that particular area so that you can see the movement coming specifically from that joint or specifically from that area, rather than accidentally putting like all of your body. I can't really show you my leg, but I guess for upper limb, when we were talking about it, for example, if we're testing the power in the wrist sort of area, it's always good to hold the muscle here, so then you're not accidentally putting any sort of power from the shoulder or the elbow joint, that sort of thing. So yeah, same thing applies to lower limb as well. And when you're doing power, or testing power rather, always good to test active movement first to make sure that the patient isn't going to be hurt by any sort of rapid movement that you do without checking how strong they actually are. Yep, so next thing to test when we're doing this examination is reflexes. Reflexes is another thing we've gone through in quite a bit of detail, and as always, you've got this sort of, rather than terminology, I guess this sign that you use, the pluses or the 0 if there's absent reflexes. So that's what you would use if someone were to kind of record this down, and that's just for your own information for when you go into placement and when you become a doctor. It's quite common to use this sort of way of recording it. Yeah, so with reflexes, if you have a patient who, well, it seems like they're putting a lot of like brain power into concentrating on the reflex, so you're not getting a very accurate representation of the natural reflex, you can always ask them to like close their eyes, clench their teeth, just focus on something else to distract them so that you can get the most natural reflex without them really paying attention to it. And yeah, whenever you're testing reflexes, always good to place your finger on the point that you're going to be hitting so that you don't hurt the patient there, and you're able to get a better sort of grip on the area as well. So with reflexes in the lower limb, you're going to be testing in the knee, the ankle, and then also the plantar reflex. I've just taken a screenshot here from Raman's notes, and these are like amazing, very, very succinct. So really good to kind of revise through your reflexes. So for example, with the knee, you have the patient's legs are freely dangling. You use the tendon hammer to strike the patellar tendon. And if there's a normal response, the quadriceps contract and the leg extends. So that's like, say for example, that's the knee joint there. You hit it there, and then it'll come up like that. This will contract and this will extend. So pretend that was my leg there. So that's an example. Yeah, and just feel free to look over the ankle section as well. Yeah, and when we're talking about the plantar reflex, we are talking about the Babinski reflex. So that's another name for it. So as you can see here, you're going to run not exactly a sharp, but some sort of object very similar to like the end of the reflex hammer. So you're going to run the end of that like in that particular shape you see on the foot there. And if you have the negative sign, so there's no like Babinski reflex, then you're going to have plantar flexion of the toes. And if it's positive, then you're going to see a dorsiflexion of the big toe and fanning of the other toe. So that's a positive Babinski reflex there. Yeah, so another thing we're looking for here is coordination. So for the lower limb, coordination is these 3 main tests here. So the first one is the heel shin test. So this is, you're going to get the patient to run the heel down the opposite shin at a moderate pace, see if they're able to do that. And of course, both sides. The toe finger test, where the patient will lift their foot to touch your finger with their big toe and observe for the tremor as they're doing that. As always, both sides. And then the last one there is the foot tapping test for dysdiadochokinesia. So that is where the patient's going to tap the sole of their foot on your hand, like that, or their heel on the opposite shin. And you're going to be able to see, like, are they able to do those sort of rapid movements like that? Yeah, so moving on to the sensory system, similar to upper limb, here's just some tips to remember. Always test with the patient's eyes closed, because for something like sensory, we want to see if they are able to recognize when something is touching them, like how, those sorts of things, and you don't want them to be influenced by what they're seeing. You just want to really observe what they're feeling. So always check with the patient's eyes closed. Start proximally and move distally down the limb, except for vibration and proprioception. Start distally there first. Then always check sensation somewhere else first. So in this case, like the face is always a good place, just somewhere where you know that their sensation is appropriate, so you can get a good sense of, like, for example, like how like what normal sensation is to them rather. And then the last point there is just always remember to check sensation on both sides, because something that's always very helpful is like that comparison between limbs rather than just one particular limb, especially even if you do know there is a pathology on one leg, you want to compare it with what their leg would be like normally. Yep, so these are the different parts of the sensory system we're looking at here. So we'll start off with pain. This is very, very similar to upper limb. So hopefully this is a bit of a revision. So yeah, checking between a blunt and a sharp object, of course, without harming the patient. The sharp object should still be like obviously sharp though. And usually test down the limb and you make sure that they're able to differentiate, first of all, that they can feel that prick or the touching, but also that they can tell the difference between what is blunt and what is sharp. The next thing there is temperature. So always good to use something like a tuning fork, just test that they're able to sense the cold. Next thing is light touch. So that's using a cotton ball, just touching straight down in each dermatome. Try your best to avoid like kind of scraping rather than just like pressing down. Pressing down is better. The other thing here is vibration. So this was one of the sections that we're going to do distal first. We're using a 128 hertz tuning fork. And so make sure that they're aware of when they can actually like feel the vibration. But the other part of it is they should be able to tell when the vibration stops. So as you are holding the tuning fork, you'll eventually kind of like help it stop vibrating. And you have to get the patient to make sure that they are aware of when it stops as well. The other one where we do distal areas first is proprioception. And if it's normal at the distal joint, then you don't have to test any further. So if a patient has no pathologies there, then that should be quite easy to go through. Yeah, oh, my bad. I did copy this from upper limb because like I said, very similar. So it wouldn't be finger here, it would be toes. And I'll make that change after. So you hold their toes from the sides like this. If this is someone's toe, holding it like that. You're going to show them each specific movement, or what you would call a movement. So if this is in the center, you're going to say, so this is the center, this is what up is, and this is what down is. And then after that, when the patient has their eyes closed and you're not going to tell them exactly what you're doing, you are just going to move either up, down, or keep it in the center, and you have to get the patient to identify which direction you're going, just to double check that they're able to do that without you letting them know and without them seeing. So that's super important. And yeah, so for anyone who's seen the upper limb revision session that we did, where I did proprioception, I had said the wrong thing, but I've just made a change for that in the comments, and it's very similar to what we've just spoken about now. So just in case you haven't checked the comments yet. And the last thing here to look at is 2-point discrimination. So using a paperclip is always a good idea, because then naturally you can just unfold the paperclip. It's got the 2 points there, and just making sure that the patient is able to differentiate between 1 point and 2. So it's always good to keep the 2 points 3 centimeters apart for feet, and for the toes specifically is 0.6 centimeters apart. And at those points, they should be able to tell that 2 different points are being placed down on their feet. And I think that's us all done. So thank you so much for watching the video. As always, please feel free to message us with any questions that you have. All of our Facebooks are in the post that was made recently for this week. But yeah, thank you so much.